good evening. I'm Melisa Idris.
And I'm Sharaad, Kuttan.
You're watching Consider This, the show where we want you to consider and then reconsider what you know of the news of the day. The 1st of December is World AIDS Day, and as at the end of 2019, the global death toll from AIDS was roughly 33 million people since its onset over 40 years ago. Now, in all, 76 million people have been affected and infected, and scientists estimate that another 1.7 million people continue to be infected with HIV every year. Where does Malaysia stand in its fight against this epidemic? Joining us on the show tonight, we are delighted to welcome Professor Datuk Dr. Adeeba Kamarulzaman. Now, in early July, she was appointed President of the International AIDS Society, which is the world's largest association of HIV professionals working to reduce the impact of AIDS. Dr. Adeeba is also the Vice President of the Malaysian AIDS Council and the Dean of the Faculty of Medicine at Universiti Malaya. Good evening, Dr. Adeeba. It's good to have you here.
Hi,
now,
sure.
Scientists discovered the virus, I believe, the virus that causes AIDS in 1983. That means that this has been an almost 40-year epidemic. Do you think that if the same speed and urgency that is behind the search for a COVID-19 vaccine was put behind the HIV and AIDS epidemic, that perhaps we would have seen an end to this epidemic decades ago?
Yeah, I think, Melissa, it's hard to say because, you know, that knowledge, that scientific knowledge has been cumulative. And I would say that, you know, the COVID-19 advances, literally advances in the last 12 months, so much so that we have 3 or 4 vaccines ready to go very soon, benefited from these years and years of HIV research. I think, you know, it's all cumulative, there was definitely a delay from the time that, you know, people were presenting in 1981, young gay men were presenting with unusual diseases. There was definitely a delay in recognition of the disease and, you know, the famous story of how Ronald Reagan, for years as President of the United States, didn't even utter the word AIDS. So that put a lot of delay in research. But subsequent to that, I think, you know, it's not a simple virus to study. To this day, we don't have an effective vaccine. So, yeah, I mean, it would be nice if it was kind of fast-forwarded a little bit more than what it is now.
What are the other factors that go into the mix when we call? I mean, it's obviously a hypothetical. I mean, as you say, one is scientific knowledge that we've gained, and you say primarily through the research over the HIV virus itself, right? But what about the other questions of, you know, political will that you've already alluded to, and also the way in which people have organized globally around disease?
Yeah.
How has that transformed over the last 40 years?
Yeah, so I think HIV did all of that. And in fact, activism around a disease only came about with HIV. I don't know if you recall, in the early days, groups like ACT UP demanded that the National Institutes of Health in the US chained themselves to the fences at the NIH in Bethesda to demand for to be included and for research to you know, on looking for treatment for HIV. And I think that's the activism that, you know, really helped you know, the global AIDS response, right, kind of.
I'm wondering about our approach to the way we're managing this pandemic, the COVID-19 pandemic, and how we've been looking at the HIV and AIDS epidemic previously, whether that approach is the same. It seems like there's this race for a vaccine, that we're pinning all our hopes on the vaccine candidate you know, appearing so that we can go back to normal life. But that's not the way we've approached HIV and AIDS, the epidemic. You know, there was the idea that vaccines were never a guarantee. There was an idea that treatment was something that we needed to focus on. Why is there such a difference in the way we're approaching these diseases?
Yeah, I think firstly it's because of the speed and the mode of transmission, right? So the SARS-CoV-2 virus is hugely transmissible, right? And anybody can get infected. So whereas HIV, it's related to certain behaviors, right? That can be controlled or not controlled, as the case may be. Whereas COVID is much more general. The transmission is everywhere, right? So that's number one, and hence the urgency. Number two, I think it is very important that we stick to some of the basic public health principles, whether it's for COVID or whether it's HIV and the so-called non-pharmaceutical intervention, you know, like the masking, the social distancing. If you want to equate that to HIV, it's the condoms and, you know, knowing who your sexual partners are and all of that. So there are similarities. And I think number three, what the COVID response can really learn from the HIV response, and where there are stark similarities, is the inequities and the marginalized population and the vulnerable population that we're now seeing in Malaysia that are most at risk. The groups may be slightly different. In HIV, it's people, men who have sex with men, sex workers, transgenders, people who inject drugs. In COVID-19, apart from, you know, what we're seeing, especially here in Malaysia, is, you know, the migrant workers, people who are in prison. And what the HIV world brings to COVID is, if you want to succeed, you have to respect human rights. You have to involve those who are marginalized and those who are most at risk in the response, you know, and that includes empowering them, giving them the education, giving them the know-how, engaging them, you know, in the response itself. And that is what I think, what we've learned from decades of HIV is one of the keys to success.
And how much have we done that in Malaysia, including people, the stakeholders, the communities, in the conversation about controlling HIV/AIDS?
As far as HIV is concerned, we're doing pretty well in that. Of course, you know, there's always room for you know, more. The Malaysian AIDS Council was actually established by the Ministry of Health precisely for that, to kind of oversee all the grassroots organizations that are involved in HIV prevention or treatment programs. And so, you know, well, until recently, we had someone living with HIV as the president of the Malaysian AIDS Council. We have groups that specifically provide prevention services, especially like needle syringe programs that are often delivered by either people living with HIV or people who use drugs or ex-drug users, likewise with sex work programs. So we try very hard to involve and empower community organizations, yes.
All right, Dr. Adeeba, we're going to take a quick break, but after this, we'll come back and take a look at what the data is telling us about transmission trends. We'll be right back with more. Stay tuned. Hi, if you've just joined us, you're watching Consider This. I'm Melisa Idris. With me is Sharaad, Kuttan, and we're speaking to Dr. Adeeba Kamarulzaman, President of the International AIDS Society, in conjunction with World AIDS Day. Dr. Adeeba, so let's talk a little bit about the transmission trends, what we know so far. What are the changing demographics of how this disease spreads? What is that telling you? I'm wondering because I'm asking how we can read those numbers in the context of things, as opposed to just taking the absolutes.
Yeah. So in Malaysia, let's stick to Malaysia. Back in the late 90s, early 2000, we saw an explosion of HIV infections amongst people who inject drugs. So we were seeing up to 4,000, at its peak, 6,000 new infections amongst people who injected drugs. amidst a lot of negativity and pushback, we managed to introduce the controversial needle syringe program and the methadone program. But as you saw well earlier, the reduction in the number of new infections amongst people who inject drugs drastically over the last decade or more since the introduction of what's known as harm reduction to less than a few hundred per year. So, you know, one can say that it's a success. And the lesson there is that if you implement policies based on science and you invest in, you know, a program that's been proven to work elsewhere around the world, you're going to get good results, right? Even if your ideology tells you something else, right?
Yeah, and I want to just stop you there. If you could just help us understand what's controversial about the needle exchange program. Is it because it says, well, if you're going to take drugs, we're not going to stop you from taking drugs. We're going to let you take drugs. We're going to help you do it in a safe way. And that's what's controversial, isn't it?
That's what's controversial. That's because you are saying it's okay. Well, those who are against it are saying, you are saying it's okay to use drugs.
Right.
You know,
and what you're saying is you're being agnostic. You're saying we can't make a judgment. What we want you to do is to reduce harm to yourself.
Correct.
And others.
Yeah.
Right.
Yeah. And abstinence is not an easy thing, you know, that it takes time. And so the methadone program, which goes hand in hand with clean needles and syringes, is to reduce the craving. And so it, you know, kind of gets someone to use methadone, which they take by mouth, instead of injecting. That's another modality by which we reduce the harm or reduce the risk.
Okay. So if you're saying that, you know, the intravenous drug uses, that mode of transmission has gone down, and I understand maternal-child HIV transmission has also been eliminated in Malaysia. Does that mean that by default sexual transmission will then go up? Is that how we should read the numbers?
It's not by default. I think it actually has gone up compared to what it was, you know, 2 decades ago. And the sad thing is it doesn't need to be that way, because if we treat everyone who is HIV positive, who's living with HIV with this effective treatment, and you bring the level of virus down in that person to what is known as undetectable, then that person will not transmit the virus, whether to their sexual partner or to their unborn child. You know, that's the concept of U equals U, or undetectable equals untransmissible. So that's very important from a public health. So treatment is not just important for the individual, which will allow them to lead a normal, healthy life, productive life, but also from a public health point of view, it reduces transmission. And it's been shown around the world, if you're in countries where you know, the uptake of treatment is high, you see not just a reduction in death rates, but you also see a reduction in transmission.
To what extent is Malaysia, you know, in the context of these global conversations, really taking on board? And when I mean Malaysia, I mean the policymakers, whether by stealth or by, you know, really keeping things under the radar. Because you can be effective by keeping things under the radar. You don't have to publicize everything, do you?
No.
So tell us, how does it actually work in Malaysia, and how responsive, from your perspective, are Malaysian policymakers and people in the, you know, on the levers of power to these global conversations?
Well, I think, you know, when we introduced the harm reduction program, it was a shock to the rest of the world, because Malaysia is very well known for having a punitive approach to drug use, and you know, we were looked upon as like leaders in the region, if not the world, coming from where we are, where we were. But from other aspects, you know, we have done quite a bit. You know, the elimination of mother-to-child transmission, the free treatment, and we can be truly proud that the majority of our HIV programs are supported through domestic funding. We've got a smallish global fund, you know, that has helped complement the programs that's funded by the government. But we need to do more. We always need to do more. And I think one area that we really, really need to scale up quickly is PrEP, or pre-exposure prophylaxis. Again, in countries where scale-up of PrEP have taken place, you're hardly seeing new HIV infections.
Can
Australia, for
very
example.
quickly just tell us a little bit about PrEP, for those who may not be familiar?
So PrEP is, to treat HIV, the person living with HIV has to take 3 different types of drugs, because that's to make sure that you attack the HIV from every angle to reduce the possibility of the virus gaining resistance. One of those 3 drugs, called tenofovir, has also been shown if the person who is not HIV infected takes it every day, and am I allowed to say this? Have sex?
Yes, you are.
I just did. Then, if they take this PrEP tablet, the tenofovir, daily, it has been shown to prevent them from getting HIV infected, pretty much like the oral contraceptive pill.
Okay. How much does it cost? And cost one of the issues for PrEP?
Not anymore. I mean, it still costs around about, I think, about 250 ringgit a month. So, you know, it's not bad, but it's, you know, in countries where PrEP is given free, it's of course a lot better and encourages people to use it. And the other exciting development is, so, you know, after a while, people can tire of taking tablets every day, right? So there are new studies that involves what's known as long-acting injections. So long-acting cabotegravir is the name of the drug. By giving an injection every 2 months, it has been shown to reduce infection in women, in men who have sex with men, and in transgender. There was a huge study, the HPTN-084,
yes, that's right, yeah.
that was released. The results were released on the same day as the Pfizer vaccine that it just got drowned. But to me, this is equally exciting because we have the tools to prevent HIV.
I want to come back and talk a little bit about that and why this is such an important development. We're going to take a quick break, but more with Dr. Adeeba in just a few minutes. Stay tuned. Thank you so much for staying with Sharaad and I on Consider This. Let's continue our conversation with Dr. Adeeba Kamarulzaman, President of the International AIDS Society, which is headquartered in Geneva, Switzerland. But she's here in the studio with us tonight. And, you know, just before the break, we were talking about the recent developments of the injections that could prevent women from contracting HIV. Same day, Pfizer came out with their press release about the vaccine. It really stole the thunder, I have to admit. Tell us why this is so exciting and important to take note of in terms of the prevention of HIV transmission.
Yeah, so an earlier study called the HPTN-083 was focused on men who have sex with men and transgender, also showed equally good results. But I think this study that was, it was studied around the world, but a lot of it was done in South Africa, was hugely important, where there are lots of women getting infected. And, you know, we've tried condoms and we've tried education, and it's not always successful, right? And because of this gender and power imbalance between women and their male sexual partners, having something that, you know, they can go to and get an injection every 2 months and know that they you know, are going to get protected from getting HIV is huge.
Right, but presumably this could be applied to anybody or any group that's vulnerable.
Correct.
Or in a situation where they might not be able to negotiate safe sex.
Correct. So hence earlier groups that were studied was men who have sex with men and transgenders, but absolutely anyone.
Right. I want to ask you about drugs, because drugs have become such an important part of actually the public discourse. We're probably more aware now about pharmaceuticals, big pharma, drugs, how they get distributed, how they get made, cold chain. Oh, my goodness. Who would have thought? That's right. So then the question really is, with all these things, what needs to be put in place so that even a drug is discovered, it gets to us in Malaysia or to wherever it needs to go in the world in a way that is equitable, that's just, that, you know, that doesn't put a burden on people and therefore makes it much more effective socially.
Yeah, so again, lessons from HIV, you know, there was this huge inequality back in 2008 when the, you know, the cocktails, as they were known then, were known, you know, and I recall one of the very first patients that I treated way back then when the drugs were discovered had to pay 2,800 ringgit a month for this treatment. And the pivotal event was actually the AIDS conference in Durban, where, you know, Nelson Mandela was there, and everyone said, this is not right. You know, the global north were receiving these drugs, and the global south, where the burden of the pandemic was most, were not getting the drugs because it was, you know, 2,800 or the equivalent at the time. So that led to the birth of a WHO and World Bank kind of initiative called the 3x5, making sure that 3 million people would receive antiretroviral treatment by 2005, something like that, you know. And everyone thought at the time, wow, this is really ambitious, how are you going to do this? But by the world galvanizing to this target, then came, you know, innovations like generic medications, bringing the price down. And that's how we in Malaysia were also able to access these drugs at, you know, no longer 2,800, but down to 200 something ringgit. And now we can give free antiretroviral therapy to everyone. So that activism that we called, we talked about earlier, that leadership, that kind of the world coming together, all that happened with HIV. And so I think, you know, now we're seeing in COVID, we've got the ACT accelerator, which COVAX is part of. It really is learning from all of that, that if you want this to happen, you've kind of got to work together.
Well, the one thing that I think the world should also pay attention to was with I guess, HIV and AIDS, you know, human behavior, understanding human behavior and the need to treat the disease with, you know, including human nature into it was also quite important. How do you think COVID has, our management of this pandemic has forgotten to include, to assess human nature and human behavior? What do you think?
You know, I mean, you can't see a more stark difference than, say, Malaysia and the US, right? This whole, you know, I'm not wearing a mask because, you know, you're infringing on my basic freedom. So that talks to us about human behavior, right? Whereas here in Malaysia, we, at least during the first wave, everyone kind of behaved, right? But, you know, what most people are concerned is the fatigue around having to be cooped up and
not abide
kind of
by,
yeah. So yes, we kind of have to respect that human nature is such that you know, they want to socialize, they want to be out there, and that's why I think in the 10 months, 11 months since the pandemic, we know much more, right? We know that being in an enclosed space like this, although this is quite large, but puts us more at a risk compared to if you were interviewing me in Dataran Merdeka, for instance, you know? And so let children go out and play. You know, I'm a bit concerned at seeing some pictures of the playground in Selangor and other places are tied up, locked up, you know, because we do need to get the children out there to play and be children. The risk is minimal, right? So we need to adjust our restrictions based on the new science that's coming out around COVID. And because, you know, human beings are not going to kind of stand to being told these restrictions forever.
Right.
You know, it's just human nature.
And one last question, the last 30 seconds. Are we following the science when it comes to HIV/AIDS? In terms of our policies, are they founded on the science or what we know?
I can probably say, I think we are. I think we are. You know, we have a policy that says that, you know, we want to have PrEP. It's just taking a bit of time to get going. And of course, we need to invest in you know, making sure that the drugs are available free. The drugs for treatment are free, but for some reason the drugs for PrEP are not so. Yeah, so certain things like that, you know. But by and large, we were brave to even do something that's ideologically opposed to what the society wants, i.e. drug use and clean needles. But like I said, you know, we took the hard decision and it's paid off. It has, when we reviewed this program in, so we started in 2005, when we reviewed this program 8 years later, by calculations, we prevented 14,000 people from becoming infected with HIV. And if you project that to 20, 30 years, we've saved about, I think, I can't remember now, 80,000 lives or something from getting infected. And in terms of dollars and cents, we've saved millions. So my point is, if you follow the science, it will pay off.
Wonderful.
Thank you so much for being on the show, Dr. Adeeba. We really appreciate it.
Pleasure.
Thank you.
That's all the time we have for you on this episode of Consider This. I'm Melisa Idris.
And I'm Sharaad, Kuttan, signing off for the evening.
Thank you so much for watching, and good night.